I'm Chris Carpenter, and I'm happy today to be talking about implementation science, quality improvement, and real-world examples of how to apply this to your research. Larissa May, Kabir, Yadav, and Patty Cummings is going to be joining us via video. We'll keep this on schedule, promise to get you out of here on time. Here's our contact information and disclosures. We'll be sure to get this to you at the end as well. I'm going to skip through a couple of slides just to try to keep us on schedule. My objectives are to paint the picture of implementation science for you. What is it? What does it mean? How do you apply it to your research? And walk you through my journey there. This was work we did at the NIH back in 2014. We had a sort of consensus conference with implementation scientists from around North America to define for the NIH, for all the institutes, what is implementation science? What are the components of implementation science? And how do we start to measure this phenomenon so that when you're applying to NHLBI or NCI or maybe even PCORI or CDC, what do we mean? What do we mean by implementation science? When we broke it down into the planning stage, we felt that it was really important that the context is described, the context where this new intervention is going to be implemented, the political climate, what's already being done there, who's going to be implementing this, and have they already been doing something similar? Or are you going to need to first de-implement and then implement the procedure? So that's the planning stage of the research. The delivery stage of the research, we felt that there are some things that typically are not reported in a typical randomized control trial, and not even emphasized by, say, the consort criteria from the Equator Network. Things like the fidelity with which an intervention is applied. If you've got a nurse doing screening for depression in the emergency department, say, and you've got one nurse completely overwhelmed, disinterested, other priorities, and she says she's got a 10-item screener for depression, but her application of that is, are you depressed? No? All right, next patient. That's not applying the 10-item screener, and that's really difficult to see through research settings. We also wanted to make sure we describe how an intervention can be adapted, and what are the key components that should not be changed, and what are the components that can be changed. And that's in the delivery stage, measuring that and reporting that transparently in the research. In evaluating the results, we felt it was important to focus on external validity in terms of pragmatism and measuring that, not just reporting that this was done at 5 different centers, 3 community hospitals, 2 academic centers, but actually measuring different components of how pragmatic this will be to apply in a research setting or in a non-research setting. And there's an instrument to do that. It's called the PREZ-2, developed by Ross Glasgow in Colorado. So we felt that that was something that was going to be important in the reporting of implementation science. And then the long-term outcomes, sustainability. How sustainable is this intervention going to be once you take the funding away and take it to a non-research setting, to the community hospital down the street? What are some of the economics that we need to be considering post hoc that maybe weren't considered in the research setting that they're going to need to go into making this thing sustainable? There's also cross-cutting themes there at the bottom that cut across all stages here, the planning to the long-term outcomes. And obviously the goals. The goals are we want to improve long-term health equitably and cost-effectively in our healthcare settings. This is what we gave the NIH. This was about a week's debate and a lot of conceptualization. And then my next task was from the NIH. They said, well, how are we going to operationalize this? That's great that the funders are going to start to put this into their program announcements. Here's our framework. But how do we operationalize this so that the journal editors know this is the way to do this and the authors know how to apply these concepts? So I next turned to the Equator Network, which for those that don't know, it's a warehouse of all the different reporting standards. If you're doing a randomized control trial, it's the consort criteria. There's about 12 different variants of that now. If you're doing a diagnostic study, it's the STARD criteria. There were none for implementation science. They did not exist yet. There was the Squire criteria, the quality improvement criteria, and we felt that that was a close parallel to what we were trying to do. But putting that against the framework that I just showed you from the NIH, we felt that there was probably a few areas where the Squire criteria wasn't exactly aligned with our focus. Here's a couple criteria from the Squire criteria that they do describe the context in which this occurs. And they describe the intervention, the local need for the intervention. So I think a very local context rather than trying to disseminate an intervention across a system. They're talking very local. And the next thing that we did was that we then look at all the other frameworks that are out there. Consort criteria currently has over 300 frameworks. At that time, it had about 200 when I was looking in 2014. And we crossed it against the criteria that we had just developed in the framework. And we felt that all those red areas are areas that each of these frameworks are probably missing, including the Squire criteria, which is down there near the bottom. And another one that's very close is the consort pragmatic randomized control criteria. Again, missing a lot of these elements, dealing with the framework. How are you going to make them change their behavior? Whatever the healthcare setting is, whoever needs to be adapted, how are you going to do that? It's got to be more than, I think this is what you should do this. There are many different frameworks, ways of adapting healthcare providers' behavior and making the setting amenable to the change that you want to adapt. The scalability was an area that there's a big question mark in the Squires. They talk about local innovation and local problem setting. They don't talk as much about how you're going to take this from hospital A and take it across the country and apply that to hospital B. We felt that that was going to be an important component of implementation science, that scalability outside the local setting. So our bottom line was, at least my bottom line was, we need Equator Network criteria for implementation science. And thus was born the STARI criteria. And the STARI criteria, unlike all the other 300 plus Equator Network criteria, have two columns there. You think of the consort criteria, there's one column of information with a bunch of rows of things you need to do. Here you've got 27 rows, and most of them are split into two columns. The two columns are because you've got an implementation strategy that you need to focus on reporting transparently, and you've got an intervention component that you've got to focus on. And the reason we felt it was important to, by we I should say, this is like European, Australian, worldwide implementation scientists. This is a national, a global endeavor. So it's not just me saying this, it's not just the NIH. This is a global perspective for implementation science. We felt that you needed to report those separately so that if something doesn't work in an implementation science study, is that because the implementation strategy was ineffective, or because the intervention in that population was ineffective, or maybe both? But the only way to know that is to have a transparent reporting of both of those columns. So that's where STARI is quite unique from Squire and every other Equator Network reporting standard. One of the things that we emphasized, one of the first criteria there down towards the bottom was, what's the rationale for behavior change? And that's a good news, bad news type of story, because there are, as of a decade ago, 61 different models. How many of those do you think have been tested empirically? Like a randomized control trial testing the Ottawa model versus one of the other frameworks. They really haven't been tested. That has not occurred. In the emergency department setting, Kabir has used one of the models, but we didn't actually test the model to show that it's effective or more effective than another model. We're starting from a lot of assumptions here. And in just a couple minutes, I'll show you how those assumptions may have problems. So if you're budding implementation scientist, one of the first things you're going to be thinking about is which of these frameworks for behavior change am I going to tackle? This is from one of my colleagues at WashU, Rachel Tabak, who synthesized those 61 models and then cleverly broke them up into, are they primarily dissemination models, primarily implementation models, or somewhere in between? And this is my attempt to put that within the context of emergency medicine and what might be of value to us and the models that had been used the most often and that I was seeing popping up on study section proposals. So trying to look at frequency of use, so maybe optimize your chance at funding, and to what your objective is in using this model. So the implementation, the STARI guidelines have 27 different components, and they are, I think, worth looking at if you're really interested in implementation science. We tried to put into context in this editorial in academic emergency medicine why it was important. I picked on this poor Foley catheter study in older adults, and it showed that it was not effective to try to de-implement Foley catheter use for older adults in preventing urinary tract infections. But I hypothesized, was that because the implementation was ineffective and not enough Foleys got taken away? Or is it because reducing Foley catheter placement in the ED doesn't have an effect on urinary tract infection? Had the STARI criteria been used, the study could have illuminated that difference. And so I tried to highlight that in this editorial. We've got Lauren Sutherland in the room, and she's helping me with a paper for the Journal of the American Geriatric Society, trying to look at, through the lens of geriatric emergency medicine research, which is my area, if we try to apply STARI criteria in an older adult population, what are some of the problems we're going to come up with? And we broke that down into the general barriers, the population level barriers, and the evaluation barriers. There's some pretty unique things about research in the older adult that we haven't really defined well. And I'm pretty sure this will probably be true if you took STARI and put it through a pediatric lens, or you took STARI and put it through a trauma services lens. I think there's going to be some uniqueness to measuring these phenomena that are in that framework, in the STARI guidelines. that we just didn't consider when we were trying to build the ship of the STARI guidelines. Before I forget, I just wanted to say that there is a abstract today at 5:05 that actually looks at the STARI reporting guidelines in 20 different implementation science journals and how well they've actually been applied the first 2 years since we published STARI. So if you're interested, check out that. I think it's in Bayside B. And point of just to take away my biases, it's my daughter presenting it. So don't be too hard on her if you show up. But that's our way of seeing how well these have been used. But I hope I've painted a picture, at least from the implementation science perspective. What is implementation science? How do I do it? How do I report it? And then Larissa's going to talk a little bit about her actual application of this in the QI lens.
Okay. All right. Thank you. Try to keep it on time. So I'm not going to talk about the theory anymore. I'm basically going to talk about how, so you can see practically how we actually implemented this. And caveat, I'm not really an implementation scientist except by default, having done a couple of studies. So I'm going to talk about an antibiotic stewardship process that we use. So just to frame the context, I'm not going to go over this, but we focused on this topic because it is amenable to practice change. It is mainly a physician, behavioral pattern. We focused on viral URIs, so really at the intersection of patient safety and public health and infection prevention. Which was a topic that was important to our institutions as well, so kind of aligning with what they wanted from a QI perspective. And we used the CDC Core Elements. Oops, sorry. What is going on here? Oh, I see. Sorry, I'm also technically challenged. So these are the CDC Core Elements for outpatient antibiotic stewardship programs, and the CDC actually considers the emergency department an outpatient setting. Obviously, there's some nuances to our setting, but this is the framework we use, which is more appropriate than the hospital framework. So the first is commitment. So basically having the dedication to commit to improving at least one facet or one policy in antibiotic stewardship. Obviously we need to track and report data. You can't do QI without that. I think I already mentioned this, and also having some education expertise, which was basically on the physician and patient side. So you guys are probably all familiar with quality improvement. This is the IHI framework with the PDSA cycles, so the Plan, Do, Study, Act. So there's some similarities with implementation science, but really there, as Chris pointed out, you're really using a more explanatory model in terms of implementing your intervention and doing that feedback loop. This is our stewardship toolkit that the CDC funded if you're interested in antibiotic stewardship specifically and how we did it. We did use implementation science methods, so there's a lot of mixed methods in there. So we did it in the pre-implementation phase. We conducted some interviews to find out what the barriers and facilitators were. We also surveyed the clinicians at our sites and triangulated those survey responses, and you can see here, pretty much corroborating what we thought. So I'm going to talk a little bit about, seems to be advancing by itself, but.
It's probably somebody had timers set.
Yeah,
So
that's probably.
so we
Okay,
can-
sorry.
I
I think it has
take the
time.
timers off, or do you want to?
Can you take the timers off?
Okay. All right. We'll take a pause.
I think you're right. I think one of these slide sets was like one of these pecha kucha format talks, and the time it's like one slide every 6 seconds. So I'm like, that's not going to work. So thank you. Okay, so this isn't the implementation science framework, but this is the premise and the literature that we actually borrowed from the outpatient setting on changing behavior. And this is all behavioral economics, so these are some of the books. This came from the economics literature and incentives, but it's also very effective at sort of changing physician behavior. And we used the principle of nudges. So we had a few characteristics. The first was social norms. So probably some of you guys have received these bills that kind of tell you how much energy you use by your utility company, where you are, and how you could improve, right? So this is kind of like the feedback or the social norms, or what we will call peer comparisons. And so for social norms, we basically gave feedback to our clinicians on their antibiotic prescribing practices. We took this straight out of a study that was what some of our co-authors had previously published. And basically, we had a congratulatory letter, and then we gave them the data. And the top 10% of providers basically got this congratulatory letter. The nice thing about the viral URI prescribing is the improvement was always possible. So basically, we got to 0 in many providers by the end of the study. We also used the nudge of identifiability. So I'm the antibiotic stewardship champion for our site, and so, basically it's this loop where, people want to do things for people that they know or like, and so that's the nudge of identifiability. And then consistency is another thing. So this is what we call public commitment, and these, you may have seen some of these commitment posters and other things, but basically reminding patients and physicians, that we're doing this project. And for the ED, we had to make some modifications because in the outpatient setting, they had these posters with signatures by the clinicians. That's not really practical in an ED, where we don't have, people don't have their own exam rooms or they see their patients, people move around. And so we basically had a study commitment log, and then we also gave people flair. So we had these so people wore their public commitment, essentially. And this is the study. So basically we looked over 2 flu seasons, 16 to 17, conducted the intervention, and then we during the 17-18 study, and that's, you can kind of see here, it's a bit of a busy slide, but definitely a downtrend. We were actually conducting a pragmatic cluster randomized trial where we were actually comparing, we were trying to compare the behavioral nudges intervention to just standard education and the CDC Core Elements, and we were not able, because our prescribing was actually so great in academic settings, because we actually don't overprescribe a lot, that we weren't actually able to show a difference between our 2 interventions, but we did show an overall downward trend there. And you can see the bullhorns. These are all the 9 different sites, and you can see where the bullhorns are where we started the education about the intervention, and then the little envelopes are where we did the peer comparisons and sent the feedback to the clinicians. And so there's probably a big Hawthorne effect here, obviously, but that was how we kind of did it. But then on the implementation side, which is typically not done with these trials, we did look at some implementation outcomes, not all of them, but we looked at acceptability, right? So what people thought about antibiotic stewardship in the emergency department, whether it would interfere with usual practice. We looked at fidelity to our intervention, so how good were we at actually, completing the components of the intervention we said we would. And you can see 100% of interviews, because we had to talk to individual people, but I thought that 52% of survey completion was actually not bad, based on prior work I've done. And then what percentage of the components do we actually adopt? And so you can see we were actually pretty good at that. I've actually looked at some data. This is data for UC Davis, so it's not all the sites, but I have looked at some of the sustainability of the ED interventions, which we did not look at in the original study. And you can see here, overall, our trend, even though prescribing rates are low, overall our trend has continued to go down and kind of stabilize. And we've done the same thing in the outpatient setting with similar results. So limitations, obviously our sites were all academically affiliated. It was only 2 states in the Western region which have the lowest antibiotic prescribing rates in the United States. And so the local context and culture might differ elsewhere, and Patty will also talk about that, our subsequent steps. We didn't look at sustainment, although, like I said, I threw some data up there for you. And then also there might, I don't think there were any harms, but we didn't actually assess that. And also there are other implementation theories that can explain or emphasize other aspects of practice change. So this is just one model. I already showed you the toolkit, and we'll talk in a little bit about testing for scale and spread. So lesson learned were that nudges work. You have to get your clinicians to buy in, and we really did focus on the low-hanging fruit. We had a lot of operational support and leadership commitment, which was really important in making this successful. And that implementation science and QI can be a framework for evidence-based program implementation. And whether you're able to actually use implementation science, and in part depends on how much of a lead time you really have in planning this, and also funding. And I think I'll stop there.
Sorry. That's going to happen again. Just warning you. Okay. Hello. I'm Kabir. I'm going to talk to you. This is not the title that I tried to get this funded on, because that would be way too breezy. But after having done this project in multiple academic centers, as it turned out, the public hospital system that I worked in took a shine to this, because one of our paid quality metrics was on reducing antibiotic prescribing for bronchitis. So lo and behold, mitigate 2. As with all these types of projects, it's a team effort, so credit where credit is due for a multiplicity of experts and talented folks involved. So what were we doing? So we were taking the prior study, we were adapting it into a public hospital system. This is the second largest county hospital health system in the country. What we did was a 12-month stepped wedge cluster randomized implementation intervention. And the goal here was to see if it worked in a public hospital setting where not all the sites were salaried folks, not all the sites had academic affiliations, so we were trying to work in a more diverse but public hospital setting. So where we picked the highest prescribing settings at here. So this is LA County DHS, so the 2 EDs and 7 urgent care centers. And we were targeting all the providers. So this was physicians, advanced practice providers, and for the interviews that we did to understand each local practice setting, we did sampling of physicians, nurses, and administrators. So again, taking the twin approaches of looking at the implementation itself as well as the impact of the intervention. First off, the adoption, we were able to successfully roll this out at each of the sites. In terms of acceptability, this was based on surveys. People felt it was both acceptable and they were willing to have a go with it. In terms of fidelity to the toolkit components, we identified local champions to serve in that role at each of the sites. We were able to complete almost all of the stakeholder interviews. I will point out that LA County is huge, and it took a lot of driving to get to all of our sites. So we got most of it done. And then we had a decent survey response rate at 58%. And then email being as it is, we were able to complete those on a monthly basis to all the sites. Other implementation metrics, penetrance of the intervention. So it's not just that you got it to the site, it's whether you actually got it to each provider. This was one of the challenges, and I would encourage you to explore this with your IRB, that QI should not have the same regulatory requirements as clinical research, because there is a component of actual improvement iteratively to the health system, which is actually in service of improving patient health. And so there's actually some very good articles that have been written that we were actually able to change our IRB's mind about this. Unfortunately, because I got the IRB approval before this change was made, I still had to get written informed consent from every single provider. So 53% was what I was able to get across the county of Los Angeles. But you could imagine that if you had done this with the appropriate preparation, you wouldn't have to get informed written consent from every provider. And in terms of how we did, so inappropriate prescribing went down from 8.1 to 4.3 among 584 providers across almost 68,000 patient encounters. The adjusted decrease was modest at 2.1%. But this, again, had to do with some of the challenges that we've been finding, which is, are we targeting this intervention to the right setting? So we didn't know this going in because the quality metric being reported to Medi-Cal gave numbers that seemed much, much higher. But you can imagine while we were doing this, they were already getting feedback about how bad this was, so there was probably improvements already happening. The other thing is that we used a much more consensus-driven definition of what inappropriate prescribing was than what the NQF had designed. So chances are, I mean, not chances are, we knew our number of inappropriate prescribing was more clinician-friendly than what the NQF was using. So in terms of facilitators, leadership support is always important, so that allowed us to get this done. So that included an implementation science award from some forward-thinking members of our leadership. Health IT prioritization is what makes healthcare work these days, so we were able to actually get our reports that we needed to get the project done, and obviously knowing that this was something that the health system felt was important certainly got hearts and minds involved. Making it a quality and safety issue was important, and like I said, this was an incentive program set up by Medi-Cal, so there was clearly an incentive there to get it done. Stepped wedge made it easier for people to be willing to do it. Nobody wants to be the control of an intervention meant to improve patient care, so stepped wedge does allow everybody to get involved and actually reap the benefits of the intervention if it's posited to have benefits. So that's an important consideration when you are trying to do this in a health system. The local champions were important. I will say that getting one person on board at a site goes a long way, because me showing up from all the way across LA County, I am an outsider, so you got to get a local champion there to help. And then the adaptation process, so really understanding what the local settings issues and concerns are, and adapting the intervention to meet them. And then obviously the nudges was the core to our intervention. The COVID silver lining, patients and providers really understood what a virus was after COVID. So there's that. But everybody uses azithromycin. I don't know. Anyway, that's a different conversation. So externally validated. So yes, we externally validated from our academic setting, but and we were able to use that toolkit that we had developed quite facilely for this. But again, the question was, is this the right setting or not? And then the other thing that we really wanted to think about, but didn't have the wherewithal this time around, was really looking at a causal inference model or a structural equation model of how different setting factors and provider factors actually influence the ability to actually create change. And so that was something that we started thinking about here, but we're still continuing to cogitate on that. With that, I will hand over to Patty Cummings over at Eisenhower Health. She's sort of here over Zoom, but she pre-recorded it, so I'm going to see if it works. And if we do, she'll be here to answer questions at the end, but I think this will be a more reliable way to get this done. So let's have a go with it. First off, it might be super low. Well, let me lower it just in case I don't want to blow your ears off.
Patricia Cummings, and I'm going to talk about utilizing behavioral science to improve antibiotic prescribing, specifically how we implemented Mitigate in a large rural community hospital in Southern California. First, to give context, we are a 463-bed community teaching hospital with a number of residency and fellowship programs. We are located in Southern California in an area known as the Coachella Valley, which includes Palm Springs. There are many rural areas within the valley, and we have a large older adult aging population, large HIV/AIDS and MSM populations, as well as very high syphilis rates compared to the rest of the United States. In terms of context specific to this project, we were seeing high rates of antibiotic use in our urgent care locations, not only within our health system at the time, but also in the community across other urgent care centers in the area. So to confirm this, we created a query to establish our baseline rate. This was all part of a national push back in 2016 when Fleming Dutra et al. Published their seminal report on inappropriate prescribing among U.S. ambulatory care visits, and that established the national rate at about 45%. As does much external federal and state policy and research, this report really gave us the impetus to start examining our own prescribing rates for acute respiratory tract infections. And when we saw it was above the national average, we decided to target our efforts in our urgent care clinics. So one of the key factors that drive any intervention, no matter where you are, is site readiness. The main purpose of this slide is to show all the external and internal facilitators that we had to implement this intervention in our health system. The orange boxes are specific to our health system, and the blue boxes are national or state level policies, regulations, or guidance documents like the CDC Core Elements of Outpatient Antibiotic Stewardship. The green boxes are key facilitators that specifically helped our antimicrobial stewardship program be successful with implementation. For example, here you can see the publication of the Mitigate Toolkit there on the bottom right in green, as well as a state collaborative that facilitated networking opportunities with colleagues that were experts in this area of research, specifically Dr. Larissa May and Dr. Kabir Yadav. So how did we implement Mitigate? We started with getting our C-suite and departmental leadership on board. Then we worked on creating the database, validating the data, and analyzing it to establish our rates and ability to track trends over time. Personally, I have an epidemiology background, but you could have a PharmD or PharmD residents do this work, your infection prevention team, or another ASP team member. For other intervention components like patient education, we leveraged our nurse managers at each site to place the printed materials in plexiglass stands in the waiting room and patient rooms. However, I would say the majority of the work and time goes into creating the clinician feedback and peer comparison emails. This takes me about a few hours to do once a month, and the time really depends on how many providers you have involved in the intervention. I also have someone conduct a cross-check before the emails get sent out for accuracy. So to go in a bit more detail on the data side, our business intelligence created a SQL database using ICD-10 codes listed on the discharge summary in Epic. This included inclusion and exclusion conditions that we obtained from the Mitigate toolkit. For the emails, we adapted content from the Mitigate toolkit, which provides templates. We then sent them to individual providers as well as group email with a color-coded blinding ranking so they could see where they stand against their peers. And that's pictured on the left, the blinded ranking. This really helped to drive competition among providers. So the bottom line is the Mitigate toolkit really gave us everything we needed to implement the intervention. Now, here are the intervention results. The green bars show the number of prescriptions written for ARI.
That's kind of visual. Give me 1 second.
Hey, how are you? You were rebooting that?
No. It was, didn't change anything, but the blue screen kind of bugged out again. There it is. Oh.
And the blue bars show the number of ARI encounters or encounter count. And then the blue line there shows the percentage of antibiotics written for ARI. This metric is simply the number of prescriptions written for ARI divided by the number of ARI encounters for each month. Once the intervention was implemented, you can see the large decline over time. And we conducted an interrupted time series analysis, so you can see the 16-month pre-intervention solid black line compared to the 6-month intervention dash line at our urgent care clinics from 2017 to 2019, and the reduction was statistically significant. So just looking at crude counts here, we had a reduction from 73% at baseline compared to 59% during the intervention, and we published these results in OFID. One other piece of data I want to mention is we use patient satisfaction surveys. We got very few patient complaints over the intervention period, but here you can see 2 examples. The first said, there appears to be this overriding fear of prescribing antibiotics that has truly pervaded our care facilities. I was tested for strep and was negative, and they go on. The second patient said, I was denied a prescription because I was told it was viral. I was given a Z-Pak last year. So we really use these to gauge patient-provider communication, and we saw it as a positive on the provider side. So the main lessons learned from implementing this intervention include patient-provider communication. So we initially gave providers symptom relief prescription pads, and we got them for free from the California Department of Public Health. And the providers ultimately did not like them because they wanted something integrated within the EHR. We use Epic, and they wanted it to be electronic so that it could be printed out as part of their AVS or after visit summary. Providers did feel, however, that giving a patient something makes them feel like they've been treated. So this can improve patient satisfaction. The second thing is identifying the best forms of provider communication for the feedback emails prior to the intervention. For example, personal versus work emails. And this may also vary across departments and specialties. The third is provider visit volumes can vary, so making sure you have enough volumes for peer comparison to make it meaningful. We excluded providers with less than 10 ARI visits per month. We also conducted a physician survey using SurveyMonkey pre-intervention that collected information on prescribing behaviors, and we found this to be an effective way to gather data quickly. Lastly, during the intervention, we found it useful to promote the message to providers that feedback emails were not meant to be punitive, but rather educational. So just want to say special thanks to our team who helped us with this work, and thank you for your time.
All right, so that's actually the end of the demonstration of some of the implementation projects that we underwent. I would just point out some sort of high-level things to consider about how this actually can work in various healthcare settings. So one is aligning the interests of your various academic hats. So acknowledging the fact that a lot of people are on the clinical service line, and high-quality QI is both a benefit to the health system as well as a publishable and scholarly work. So I think you guys, if you're considering that, you're doing the work already, this is an opportunity to align that work that you're doing into something that has academic value. And the hospital's obviously interested in quality initiatives that align with what they want to see. And then the other thing just to point out is that ACGME has shifted an emphasis onto QI as an opportunity that both residents should be exposed to, as well as an opportunity to provide some scholarly output as well. The other thing about quality improvement and particularly implementation science is that your people with expertise are going to be outside of your department. So finding those experts, whether they be in social work or nursing, if you are academic affiliated, finding folks in human factors engineering, psychology, or sociology. And there are, of course, consulting groups and community groups that also have expertise. And the last thing is that here at SAEM, we have an evidence-based healthcare and implementation interest group. So if this is something that you have an interest in and kind of want to figure out how you can get like-minded people to help you out, that's an opportunity for you as well. And then as far as funding, like I said, we did have, well, 2 of the 3 had funding, and we're actually embarking on a 4th one that also has industry funding to do this. Curiously enough, a company that makes antibiotics wants us to prescribe less, but we'll take it. And then the other thing to leverage, both in-kind support from your health system or your academic affiliated center, and that can be in the form of a Clinical and Translational Science Institute award. They have a lot of internal vouchers and seed grants that can be of benefit in that. And then look outside the walls of your academic home and your clinical home. Foundations and community trusts are also interested in this kind of stuff, especially if it's addressing healthcare disparities. PCORI has an implementation science interest in their methods, and the institutes at NIH, thanks to the work that Chris Carpenter has helped lead, has actually integrated implementation science across their funding opportunities. So certainly talk to a program officer if it's something that you would like to integrate into your work. And the last thing is that there are training opportunities. This is the post-pandemic pandemic era anyway. So there's a lot of stuff that you can do asynchronously online. The TIDER program was a training institute for dissemination implementation research in health. That ended in person in 2020, but the open access modules are available online if you want to go at your own pace and learn that. There are other certificate programs from various university affiliates, including the Institute for Implementation Science Scholars at WashU. Last but not least, I'm going to leave this slide up while we take questions, but this is feedback requested. This is a research committee sponsored didactic, and they'd like to know what you thought. So thank you. Questions?
Oh, thank you so much. Coming to SAEM for over 20 years, as always these nerdy research didactics that really get me juiced. Chris, you know, the 61 frameworks, what are we going to do about the fact that the academic system of reward for publication mandates that we all make our own tinily different framework? Like that we're constantly splitting and trying to find a small difference, as instead of replicating, and looking at the broad commonalities, so that these implementation frameworks keep multiplying and multiplying because that's the way you get promoted, right? As opposed to saying, hey, our framework has in common with these 60 frameworks these elements, and no, we don't need a 67th. Is that a question? Is that did I express myself?
The bad news is that was a decade ago when we had 61. There's over 100 now. So that was a decade ago. My answer, and there's no consensus on this. In fact, most of the implementation scientists, like theorists, don't want to talk about that problem. I think in our specialties, we need to start through head-to-head testing to see which ones make the most sense for the work we do. Kabir and Lewis have actually used some of these frameworks in their research. They might have different opinions, but I think that's the only way to get to a meaningful answer is to test them and see which ones have benefit.
Yeah, we certainly didn't have an opportunity to test head-to-head. We worked from the ones that seemed to make sense. For most of our work, we used a dynamic adaptation process because it felt right for emergency care where things seem to change week to week, day to day. But it did give us that opportunity to really focus on the adaptation for each single site. But yes, you kind of have to look at where you are, and we were certainly not looking to create a new framework. We just wanted to get the work done.
What's your bigger picture about scholarly productivity, though, and the publisher parish? You got a segment on MRAP this month. It's in the Proctor ET segment, EMA. We talked about that exact issue. So you might like to listen to that. There are some ideas thrown out there.
This is a question for Dr. May. There's so many behavioral change techniques, and you said you used several different types of nudges, but what you described seemed more like an audit and feedback. You gave people their monthly numbers. So what made it more like a nudge to you?
Yeah, I think the peer comparison, there were nudges used. In antibiotic stewardship, typically when I think audit and feedback is typically an inpatient strategy, because what happens is it's not actually in real time, so it's more of and it was peer comparison, so we were comparing people to each other, and we had some caveats around that and some FAQs, to kind of understand that, everybody was kind of like being compared to each other, but it's a good point. There are multiple different methods to do QI and implementation science. This is just one we chose because, our co-authors had been really successful with the behavioral economics in the outpatient setting. So we basically adapted the literature from the outpatient setting to the ED and urgent care, and then I actually adapted it back to our outpatient system too. So, it wasn't all theoretical. Some of the work I've done has just been very much QI. But, the fine line, I think, for me is just having that pre-intervention, really thoughtful approaches to the explanatory model, the framework, and you really need that lead time. And sometimes it doesn't work in the health system, right? The leadership is in a rush. They want things done right away. So, you have to kind of compromise sometimes. So it's messy.
The other thing I'd point out, if you're interested, is that Daniela Meeker and Jason Doctor were the behavioral scientists. They've published extensively on the topic. But the idea is you're not putting it on a poster. It's not on a lean board. This is individualized emails that are going directly to the person. And it's meant to be a little bit cognitively challenging. When a very successful physician is told they're not a top performer, it hurts. And it's meant to hurt a little bit just to nudge them in the right direction.
Yeah, it works because physicians are type A, I think.
because it's being recorded. Thanks. So by way of background, I was actually in the last cohort of TITRE, and I actually have my first NIH grant and an MSI grant, but I'm also still very much learning, and I feel like that's a lot of MSI people still at this phase. I had two questions. The first one was, I noticed you both used like survey completion and other measurement proportions as one of your fidelity indicators. I just thought that was interesting because again, still learning, but I hadn't, my understanding of fidelity, and so I'd just love to hear your feedback, and especially Chris, because you've been doing this for a long time, on like reconciling that, because my understanding of fidelity was it was sort of internal validity of the intervention. So I just thought it was really interesting that one of your measures was survey completion. So that's one question. The second question was just for my own edification, because I'm also just learning how other people use models. And I was trying to pull your slides on the app, but it's really slow right now. What model or combination of models or frameworks did you actually use? I apologize if I missed it. I saw sort of your, like you said, you had adoption fees and some other things listed, but I wasn't sure if it was distinct that you used a model.
For the original mitigate, it was the dynamic adaptation process. That's what we used. Though we had an implementation scientist on that team who also recommended that framework. Although her experience, there's not a lot of, trained implementation scientists. So she actually has done most of her work in like the community and school-based settings on autism. So like her content area was very far away, but she was really our theoretical. That's what she recommended.
The definition of fidelity that the NIH is trying to push towards is the duration and dose and intensity of the intervention. It's really tough to measure, right? How do you measure that? You might almost need to record it and then have 3 people watch and see. But that's what we're talking about with fidelity in the context of implementation science is the intensity with which that is delivered to the stakeholder, the patient you're trying to do a behavior change on.
So in this case, this was the providers, and the toolkit itself was trying to measure engagement with the provider, so that's why we used their participation in the surveys. A little short on time.
Sorry. So I understand you're using a framework to kind of base your strategy. I guess my question is, how do you then afterwards dissect the relative components of like the implementation process versus the intervention that you're designing, and how do you know the relative contributions to the success or not of your overall?
I think it's more of a bundle. I mean, it's like the bundles. I mean, you don't know exactly what worked. There, and like I said, there's a big Hawthorne effect in anything like this. So it's hard to know what actually. You can't really tease it out. I mean, you can tease out the implementation outcomes, but yeah, there was no way to link that to the primary outcome.
And that's where that structural equation idea comes in, where if different sites have different aspects, you can in some ways compare what seems to work in one setting, and if some components aren't working in another setting, and that doesn't seem to, like the impact isn't there, one would posit that it was those components that led to that poorer impact.
In the STAR reporting guidelines, there's actually 2 manuscripts. One's in B&J Open, and it does give some examples for each of those rows on how we think those things should be separated out from different fields, different publications. So you can see some examples in that B&J publication. Please email me if you want me to email you any of this information. Also, the TITRE curriculum from the 2017 class, I've got the entire curriculum online if people want me to email that since it no longer exists. So thank you.
Thanks for coming.